best practice guidelines utilized during this presentation. Um, First line drugs to treat thyroid disease. I'm going to split it up into two disease processes because you're going to treat hypothyroidism and hyperthyroidism as far as thyroid disease goes. First line drugs for hypothyroidism is always levothyroxine. It's a synthetic T4 therapy. It has three main goals for levothyroxine. You want patient symptom resolution to achieve euthyroid state, including biological and physiological signs and symptoms. You want normalization of serum thyrotropin by improving thyroid hormone concentrations. And you also want to avoid overtreatment, especially in the elderly population, which I will talk about in future slides. Hyperthyroidism is treated with antithyroid drugs, PTU and methimazole are both are first line drugs for hyperthyroidism. You want to use PTU in patients that are pregnant or may become pregnant, methimazole in those who are taking birth control pills to prevent pregnancy because you don't want them to get pregnant while on methimazole. You'll see the dosages for each medication here. You can also use propranolol or any type of beta adrenergic blocker. It's recommended in patients with tachycardia associated with hyperthyroidism. Especially you want to use this in elderly patients and patients with a resting heart rate above 90 beats per minute or has associated cardiovascular disease. Second line drugs for hypothyroidism is liothyronine. It's a um, it's a T3 synthetic T3 hormone. You can use I'm sorry, liothyronine. It's recommended in patients who remain symptomatic on levothyroxine therapy, which is your T4 therapy. Um, T4 treatment is based on the activation of T4 to T3. So if those patients are still symptomatic, that means their T4 is not being activated to T3, so they may need that additional dosage of T3. As you can see for hyperthyroidism, there really isn't any drugs for second line, but they also have second line therapies for hyperthyroidism. You can do radioactive iodine treatment, which is preferred by physicians. A 2011 survey of clinical endocrinologists, 59.7 suggested RAI treatment as primary therapy, where you will go in there and radioactively destroy the thyroid tissue so it won't make too much thyroid hormones. Some have also opted to do thyroidectomy as a solution to hyperthyroidism, as in Graves' disease. The pharmacodynamics and pharmacokinetics of each medication are listed below. Both levothyroxine and liothyronine increase basal metabolic rates. They also increase utilization and mobilization of glycogen stores and promote glucogenesis. Levothyroxine also stimulate protein protein synthesis, and that hormone, specifically the T4 hormone, is involved in growth and development, which we'll talk about as we come to the pediatric population. PTU blocks the synthesis of T4 and T3 um, by blocking oxygenation of iodine in the thyroid gland. So it kind of halts that production of thyroid hormone. Methimazole also does the same thing by blocking that formation of thyroid hormone. Beta blockers work by competitively beta 1 and beta 2 receptor inhibitors, and it decreases the heart rates, myocardial contractility, and the blood pressure which can help with those symptoms of hyperthyroid. The effects on the body systems, both your T3 and T4 synthetic hormone will have the same, almost the same side effects. You can get the palpitations, the tachycardia, some weight loss, diarrhea, insomnia, anxiety, arrhythmias, and headaches. Your T3, which is your thyronine, can also cause menstrual irregularities. Both your anti-thyroid drugs, which is your PTU and your methimazole, can cause you to have some rash, urticaria, some arthritis, fever, taste disturbances, nausea, vomiting, headache. It can also cause some liver toxicity and some aplastic anemia and cytosis. That's why when you're taking anti-thyroid drugs for hyperthyroidism, the monitoring of your TSH, your T4 free, your T3 free, your CBC and your CMP will be done more often than those who are stabilized on T4 or T3 hormone. We like to do those every 3 to 6 months because the anti thyroid drugs can cause harmful effects on your liver and your blood cells. Your beta blockers to help with symptoms can cause some fatigue, dizziness, hypotension, bradycardia, nausea, weakness, and insomnia, and sometimes alopecia in certain populations. Patients with hypothyroidism are more likely to visit the emergency department with complaints related to uncontrolled hypothyroidism compared to the euthyroid patients. Hypothyroidism is also associated with increased morbidity related to cardiovascular, neurological, psychiatric, and gastrointestinal systems. Um, Reactions to hypothyroidism. As you can see below, the chart below talks about outpatient costs, drug costs, laboratory costs, inpatient and emergency room department costs based on the study done by Health and All in 2021. Special populations, what you want to look at is especially with pediatric populations. Thyroid hormone is necessary for neurological and cognitive development. Severe neurocognitive defects can occur if thyroid disease is not treated effectively and in a prompt and timely manner. There is a universal newborn screening that we're all should be aware of, the PKU that's done on patients at 24 hours and sometimes 48 hours of birth to detect congenital hypothyroidism. Below are the doses adjusted for the levothyroxine dose, which is the first line drug for pediatric population. In pregnancy do increase the renal iodine excretion, your thyroid hormone binding proteins, and total T4 concentration increase after 7 weeks of gestation. Like I said before, PTU is the preferred medication during pregnancy. Because it's safer for fetal development. Elderly patients do have a higher serum TSH range, and the American Thyroid Association recommends that a target TSH for elderly patients be between 4 and 6 instead of 3 and 5 as we see in the younger adult population. Treatment is also initiated in low doses with a slow titration, and most of the time you'll see some providers not even treat the elderly population until their TSH becomes greater than 10 or they're symptomatic at a lower TSH. Here are my references today. I hope you enjoyed this presentation on thyroid disease, and I will answer any questions or any further inquiries or anything during our discussion post. Thank you so much.